today, advanced practice provider with Allison Phillips, MPAP, MHPE, PAC. Allison, welcome. Good to see you.
Thank you. I'm excited to be here.
And you'll be talking about oncologic emergencies, Superior Vena Cava Syndrome, Hypercalcemia, and SIADH. So we're looking forward to learning more about all of that. And rather than reading your bio, we're going to find out our top five about you. And number five is Allison Phillips, MPAP, MHPE, PAC, as a physician assistant working for the UNC Breast Cancer Group with Dr. Lisa Carey. And Lisa Carey is also a guest on this forum, so very good to have you here. Prior to joining the UNC oncology team, she worked as a provider in the local health department for nearly 8 years, specializing in women's and children's health. And she has over 9 years of clinical experience and an interest and passion for public health and improving clinical education. Allison is also adjunct faculty in the physician assistant program at Campbell University, and she has a particular interest in providing equitable health care to patients from underserved communities and improving health literacy. That's wonderful. So, Allison, thank you so much for being here. We mentioned poll everywhere. So the first question is going to be: an oncologic emergency is an acute health problem caused by the cancer or its treatment and requires immediate treatment. And so folks can decide if that's true or false in just a moment. We have our mandatory disclosures. So there's our ACCME disclosure, and there's our ANCC disclosure. And we'll give folks a few more seconds, but looks like so far they're saying, yep, that's what it is. How are they doing?
Very good. We started with a softball, so I'm glad that went well.
Good, good. And what's one thing outside of your professional bio that we should know about you? Almost forgot to ask.
Oh, sure. Well, I'm a big animal lover. I have two dogs and two cats. So
Wow.
how
Wow.
house full.
That is great. Well, thank you so much for being here. First question out of the way, and all these questions, the poll everywhere is all anonymous, by the way. So I will go ahead and turn it over to you.
All right. Thank you so much. I'm excited to be here with you guys this afternoon. This title is a mouthful, so we won't try to say it 5 times fast. I do want to start with just the caveat that after 3.5 years of avoiding it, I did have COVID last week. And so I am mostly not coughing, but I apologize in advance if I have to pause and take a sip of water or something like that, such as the times now. So we'll go ahead and get started and dive right into three of these oncologic emergencies. So these are our objectives for today. We're just going to review the clinical synopsis for three different oncologic emergencies and really go over how they present, whether they present, to an emergency setting, a primary care setting, or to the oncology office, and then how these are typically managed, just an overview of each. So we're going to start off with another poll everywhere question. Just to see what everyone knows to start with. So all of the following are true of oncologic emergencies, except they can be caused by structural, metabolic, or hematologic factors related to cancer or the cancer treatment. They can be the presenting symptom in patients with previously undiagnosed malignancy. They only present in patients with advanced stage cancer. Or they're important for all clinicians treating cancer patients to be aware of. Give you a couple seconds there. So looks like everyone's doing well on this one, and that's exactly right. So one thing I want to highlight is this can often be the presenting symptom in patients who have not been diagnosed previously with any type of malignancy. They can come into the emergency room, and then these things that we're going to talk about today can be their actual presenting sign of finding out that they have cancer. While a lot of these oncologic emergencies are more typical in patients with advanced stage cancer, they certainly can present in patients of any stage of cancer. So that is correct. That is not the true statement. So let's just review what is an oncologic emergency. So it's any acute, potentially life-threatening event that either is directly or indirectly related to a patient's cancer or treatment of that cancer. So this could be something that is caused by a chemo drug, or could be actually physically caused by a tumor or something like that itself. Again, this can be the presenting symptom for an undiagnosed neoplasm, and they're classified as either metabolic, hematologic, structural, or treatment related. So just to review, the metabolic oncologic emergencies are tumor lysis syndrome, hypercalcemia of malignancy, and then syndrome of inappropriate antidiuretic hormone, which we will call SIADH for time purposes. Then we have the hematologic oncologic emergencies, which are things like febrile neutropenia and hyperviscosity syndrome, as well as our structural oncologic emergencies. Those are things like malignant spinal cord compression, superior vena cava syndrome, or a malignant pericardial effusion. And finally, we have the treatment-related oncologic emergencies. So these are things like immunotherapy reactions, hypersensitivity reactions, and extravasation. And if you are a frequent watcher of these APP Grand Rounds presentations, there have been a couple other presentations on some of these other oncologic emergencies, extravasation, tumor lysis syndrome, things like that. So if you weren't able to watch those, I would definitely check them out, as there's no way to helpfully and do a good job of covering all of these in one talk. So we've spaced them out, but definitely encourage you to watch those as well. So we're going to start with hypercalcemia of malignancy. And you can see here on a PET scan sort of how this can present. So let's start with a case. So LH is a 61-year-old female who is recently diagnosed with recurrent breast cancer with metastatic lesions in her pelvis and spine. She presents for routine follow-up with her oncologist and reports that she's been feeling awful for the past week with severe stomach pain, constipation, frequent urination, and body aches, like I have the flu, she says. Her vitals are stable and she's afebrile. Her CBC shows some mild anemia with a hemoglobin of 11.1, and CMP shows a sodium of 141, potassium 3.4, and a calcium of 12. So hypercalcemia of malignancy is defined as a serum calcium of greater than 10.5 milligrams per deciliter. So with our case on the last slide with a calcium of 12, this patient definitely has hypercalcemia. This occurs in 10 to 30% of patients with cancer. It's most common in patients with breast cancer and myeloma, but we can also see it with things like squamous cell carcinoma of the head and neck, lungs, kidney, and cervix as well. So what causes hypercalcemia of malignancy? So there are several thoughts and different mechanisms by which this can happen. So one is excessive secretion of the parathyroid hormone-related protein. Another is the release of osteoclasts from bone metastasis. And then excessive production of vitamin D or calcitriol. And certainly what you did not hear in my bio is that I'm an endocrinologist. So I will not pretend to know the ins and outs of the pathways of excessive secretion of parathyroid hormone-related proteins or anything like that. Again, this is an overview of the oncologic emergency, how it's going to present, and how we're going to manage this for the patient. But I do want to give a little overview of the mechanism behind this as well. When we're talking about excessive secretion of parathyroid hormone-related protein, this accounts for about 80% of all the cases of hypercalcemia in cancer patients. So it's the most common reason. What the PTHRP does is it enhances renal tubular reabsorption of calcium while also increasing urinary excretion of phosphorus. It does not increase the production of vitamin D, and so therefore it does not increase the intestinal absorption of calcium. Osteolytic hypercalcemia is probably what we are all thinking of the most as far as why a patient with cancer might have hypercalcemia. So this accounts for about 20% of all cases of hypercalcemia in cancer patients, and it's associated with extensive bony mets or skeletal tumors. Previously, this was thought to be caused by destruction of the bone and that calcium sort of floating freely in the serum. But now it's believed to be related more to the release of cytokines, which can cause excessive osteoclast activation. So you can see in the picture here, osteoblasts and osteoclasts, just reminding us the difference in those. And so that's sort of believed to be a mechanism of this. And not very common, less than 1% of all cases of malignant hypercalcemia are related to excessive production of dehydroxyvitamin D. This is an extrarenal production, and it's most common in Hodgkin's and non-Hodgkin's lymphoma, but again, not very common with those either. So how does hypercalcium present? So this is what the classic from medical school or your training days of the painful bones, renal stones, abdominal groans, sitting on the throne, or polyuria and constipation, and psychiatric overtones. So I had not thought of that since I was in training, really. So I just thought that was fun to add back in. But it's a very good way to remember the presentation of hypercalcemia. So definitely bone pain is probably what patients are going to complain of or present with the most, as well as constipation and polyuria. When we're getting into really severe hypercalcemia is when we're getting some of the altered mental status and confusion. So how do we correct for hypoalbuminemia when we're trying to calculate the actual total serum calcium? So total serum calcium is about 40% albumin bound, which means that serum calcium can actually be underestimated in the patient with low albumin. So while it may appear normal in your EPIC or your results page, if they have a low albumin, you need to calculate for this as well. So I put the formula here. Corrected calcium in milligrams per deciliters equals 0.8 times the normal albumin, which is 4, minus the patient's albumin plus their serum calcium. And then this is some additional lab workup. I thought this chart was really helpful in showing you kind of what the other components of labs may result as high or low or normal, and if that's leaning more towards what underlying cause of the hypercalcemia that's leaning more towards. So how do we treat this hypercalcemia of malignancy? So as with most things related to cancer, our treatment of the underlying malignancy is the primary goal. So especially if this is due to excessive bony mets or primary bone tumors, if we treat that and get it under control, then we're much more likely to get the calcium under control and prevent this from happening again. Certainly, we want to do a careful med rec and make sure that we're discontinuing any contributing medication. So if your patient's on calcium, we want to stop that. Other things like lithium or thiazide diuretics that may result in elevated calcium levels as well would also be helpful to stop or assess for safety in stopping. These patients are also often hypovolemic, so replacing the fluids is also a big part of this as well. We usually do that with a saline bolus and then some maintenance fluids until their volume repletes. But that is more for long term. How do we quickly get the calcium down in a patient that's having symptoms of hypercalcemia? So bisphosphonates are our gold standard first line therapy. They should be given as soon as possible upon diagnosis. So within 48 hours is really the goal. Zoledronic acid is usually the preferred bisphosphonate to use. You can see Zometa on the side, not sponsored by Novartis. But zoledronic acid is kind of our preferred line here. What these do is they induce osteoclast apoptosis and prevent apoptosis of osteoblasts. And then this reduces osteoclastic bone resorption. These can be associated with nephrotoxicity, so dose reduction may be warranted for these as well. Denosumab can also be used. This is another injectable form of treatment. What it does is similarly, it reduces osteoclast activity and bone resorption. It's more effective than bisphosphonates in prevention of hypercalcemia of malignancy. So certainly in a patient who's had a history of hypercalcemia that maybe had to be treated initially with IV zoledronic acid, we want to put them on something to help prevent this from happening again, then denosumab would be the preferred treatment as well. This can also be used to treat if a patient has hypercalcemia of malignancy that's been refractory to bisphosphonates. Other treatments include calcitonin. So this is a really rapid way to lower calcium. This can cause tachyphylaxis after about 48 hours, so something to look out for as well. Steroids, glucocorticoids can be used to inhibit the osteoclastic bone resorption by decreasing that cytokine release. It can also have a direct tumorolytic effect, so it can make calcitonin more effective. As far as prognosis of hypercalcemia of malignancy, even with treatment, unfortunately, approximately 50% of cancer patients who present with hypercalcemia will die within 30 days, and not necessarily because of the hypercalcemia itself, more that this just can be an indication of the severity of their disease. It's believed to be related to this most often occurring in advanced stage cancer. So just to check in and make sure everyone's been paying attention, what is our first line treatment for hypercalcemia of malignancy? Is it IV fluid bolus, IV bisphosphonate, calcitonin, or glucocorticoids followed by dialysis? You guys are great, or I'm a really easy test question writer. So very good. I'm so glad that message came across. So IV bisphosphonates are typically the first line treatment for hypercalcemia of malignancy. Very good. All right. So moving right along to SIADH. As I gave the caveat earlier for endocrinology, nor am I a nephrologist. So again, overviews for the oncology team. So let's look at another case. MJ is a 75-year-old male who's been undergoing treatment for lung cancer for the past 6 months. He presents to the emergency room where his wife reports he has been groggy and complaining of nausea and a headache for the past 3 days. She brings him in today because he appeared confused and could not remember her name or what day it was. Vitals, you can see his heart rate is 57, blood pressure is 90/66, and a CMP shows a sodium of 118. So SIADH, or syndrome of inappropriate antidiuretic hormone, let's talk about what that is. So ADH is usually released by the pituitary gland in response to high sodium levels. Certain neuroendocrine tumor cells can cause the body to secrete too much antidiuretic hormone, which causes the kidneys to retain fluid and leads to hyponatremia. Certain cancer therapies, like some of our platinums and methotrexate, can also cause excessive ADH secretion, So the combination of these two things, or either neuroendocrine tumors in these treatments alone can cause this. As far as incidence, about 70% of all cases of SIADH are associated with malignancy. The majority of these cases are linked to small cell carcinoma of the lung, but it can also be seen with lymphoma, Ewing sarcoma, mesothelioma, or squamous cell carcinoma of the head and neck. How do we diagnose SIADH? So we know that our normal sodium range is 135 to 145 milliequivalents per liter. Hyponatremia is defined as less than 135, and severe hyponatremia is defined as less than 125. So our patient in our case with a sodium of 118 was definitely severely hyponatremic. What are the symptoms of hyponatremia? So fatigue, nausea, vomiting, headache, all of those are rather vague and typical of a lot of cancer patients. The shaking, confusion, and muscle cramping are really where we need to kind of be alert that something more specific and more severe is going on. If there's a rapid drop in the sodium, this can lead to bradycardia, hypotension, seizures, coma, and even death. So how do we treat SIADH? So like with most things, depends on the underlying cause. Also, is the patient symptomatic, or is this asymptomatic hyponatremia that you found incidentally sort of just on labs? Is this acute? So within the last 48 hours, this patient has had symptom onset, or is this a chronic thing where they're constantly having low sodium on their CMP? Urine osmolality and creatinine clearance are also important things to look at and take into account when we're making our treatment decisions. So this is important here. The goal is to raise the serum sodium by 0.5 to 1 milliequivalents per hour, but not more than 10 to 12 milliequivalents in the first 24 hours. So we want to get it up pretty quickly, but not too quickly, so we cause problems for the patient. So again, we want to avoid overly rapid correction. So this can cause CPM, or central pontine myelinolysis, also known as osmotic demyelination syndrome, much easier to say. This is a neurological disorder that can occur after too rapid of a medical correction of sodium deficiency, which results in decreased sensation, motor functioning, and coordination. And now, as far as treatment for acute SIADH, so again, this is with less than 48-hour onset of the low sodium. We want to do water restriction. We're going to give these patients 3% hypertonic saline. You can give them loop diuretics with the hypertonic saline as well, and then vasopressin 2 receptor antagonists. We want to encourage the intake of sodium at this point to get that back up. Now compare that to when we're treating chronic SIADH, and this is an asymptomatic person that you're just following on labs weekly or every couple of weeks, and they're just continuing to have low sodium. We want to do a certain degree of fluid restriction. You can also do some vasopressin 2 receptor antagonists, and you want to consider loop diuretics with increased salt intake, urea, mannitol, things like that to help get the sodium back up. All right, so another poll everywhere. Which of the following types of malignancy is most highly associated with SIADH? So is it small cell carcinoma of the lung, renal cell carcinoma, triple negative breast cancer, or Ewing sarcoma? You guys are good. someone else could be teaching this class, I think, or you're just really alert and paying attention, which I appreciate. So very good. Yes, this is most common with small cell carcinoma of the lung. All right, so that's SIADH. And that brings us now to Superior Vena Cava Syndrome. So I've put the picture here so that you can review the anatomy of the heart. If cardiology is not a day-to-day practice for you, again, we'll have a brief little overview of that. So for our final case, AK is a 56-year-old female who presents to the emergency room with new onset of headache, blurry vision, and a cough. You notice on physical exam that her face appears swollen and the veins of the right side of her neck are distended but non-pulsatile. She has a port in place in her upper right chest as she is currently undergoing treatment for non-Hodgkin's lymphoma. So what is SPC syndrome? It's a collection of clinical signs and symptoms that are the result of partial or complete obstruction of blood flowing through the SPC. Usually this is secondary to malignancy, for example, when a tumor is infiltrating the vessel wall, or from a thrombus that can be caused by cancer, as we know that that's a hypercoagulable state. About 50% of SPC syndrome cases are associated with non-small cell lung cancers, and about 35% of are associated with small cell lung cancers or lymphomas. This can also be associated with other things related to cancer, like a port placement, not the actual cancer itself, and sometimes with pacemakers as well. So again, this is not intended to be a cardiology or anatomy overview, but just remember that the superior vena cava is formed by the junction of the left and right brachiocephalic veins. So you can see that in the picture here. It is responsible for blood return from the head, neck, upper extremities, and torso back to the right atrium. So very important part of our cardiovascular system. So how do patients with SPC syndrome present? So you can see here, typically they'll have swelling of the neck and face. They may report things like headache or blurry vision. They will often have distended veins of the neck or sometimes the chest wall as well, and these will be non-pulsatile veins. So that's important to distinguish. Sometimes these patients will have a cough. They can be dyspneic or have lithopnea. They can sometimes report things like dysphagia, upper extremity swelling, and even conjunctival erythema without the infectious exudate that we think of with pink eye. So how do we grade SPC syndrome? So just wanted to put this as a review as well. So 0 is when they're asymptomatic. We see that they have SPC syndrome on imaging, but the patient's totally asymptomatic. This was sort of an incidental finding. 1 would be mild. So this is when they're presenting with some edema of the head or neck. 2 would be more of a moderate case when they have edema in the head or neck that's also associated with some type of functional impairment, whether that be they can't turn their head completely to the side, the range of motion is decreased, maybe they're having some trouble swallowing or something like that. Grade 3 is severe. This is when they have mild or moderate cerebral edema or laryngeal edema. And sometimes they will also present with diminished cardiac reserve. Grade 4 is life-threatening. This is when patients present with things like significant cerebral edema or laryngeal edema, and there's some hemodynamic compromise going on. So these patients are going to require pretty rapid attention. And then grade 5 is death, which is pretty self-explanatory how that will present. So how do we diagnose this, if not incidentally on a finding? So it's largely based on the history and physical. As we tell students all the time, the history and physical are very important. And that's just based on those physical exam findings that we discussed on the last slide, and presentation very similar to the case that we talked about at the beginning of this section. So now, as far as imaging goes, you can get an ultrasound of the jugular, the subclavian, and the brachiocephalic veins, and look for that enlarging of the SVC and the surrounding veins as well. You could also find this on a chest CT or an MRI, and that'll usually show the presence of collateral vessels as well, and that's associated with a pretty high diagnostic sensitivity of 96%. So how do we manage SVC? So step one, first thing to do is elevate the patient's head to decrease venous pressure. Very easy. Well, maybe easier said than done, depending on your setting and if you can find the remote or know how to operate the patient exam beds in your location. But all kidding aside, the first thing you want to do is elevate the patient's head, and then carry on with the rest of your management. So the further management is then determined again by the underlying disease and the cause of the SVC syndrome. So if this is related to a thrombus, then we need to anticoagulate the patient. Diuretics and steroids may have a role as well if this is a fluid overload problem. If this is port related, then we need to take the port out and get IR involved. Chemo, surgical removal, or radiation of the obstructing tumor can all be done. If this is from an actual invasion of the tumor, if those approaches are deemed safe for the patient. Thromboplasty can also be done if we're concerned about a thrombus. And then again, open surgical repair of the SVC with grafting if needed. Okay, and then this is probably something that no one as an oncology provider will be doing. This is something that's going to be managed by our cardiothoracic friends, but just thought it would be interesting to include as well the Kishi score for SVC syndrome severity. The key thing here is that a score of 4 or higher indicates a need for stent placement. And so a score of 4 really indicates that the patient has some neurological awareness disorders, they're comatose, and then we can also add up in the other sections too, things like coughing, stridor, orthopnea, facial signs. So if their lips or their nose is swollen, if they're having nosebleeds, that gives them a higher score than if they're just having a little bit of edema in the face. And so just taking all of these into account. So the real takeaway here is not that any oncology provider or person working in the emergency room who may be caring for these patients is going to be placing the stent, but the key takeaway here is that you need to get them very quickly if they've got this sort of scoring going on to the proper team who can manage that and get that stent placed. All right, so what should be the first step in management of a patient presenting with SVC syndrome? Is it anticoagulation with IV heparin, administration of vasopressors, palliative radiation to the invading tumor, or elevation of the patient's head? Oh, there we go. Well, if I had gold stars, I would give them out. We are 100% on all of the poll everywhere questions. So I really appreciate your attention and quick responses to these questions. Very good. So yes, the first step in management is elevating the patient's head, because no matter what the cause of the SVC syndrome, that can really help with treatment while we're sort of figuring out, paging the cardiology team, doing what other steps need to be done. So again, oncologic emergencies are very common among cancer patients. Unfortunately, they can not only be diagnosed in patients who are known to have cancer, but can be the way that patients find out that they have cancer. And you can imagine how difficult that can be, to be coming into the emergency room for what you think is, a very bad GI bug if you're very constipated and having a lot of abdominal pain and headache, and then finding out that perhaps it's because you have hypercalcemia of malignancy and you have significant bony metastasis. So really being aware of this on all levels, from the primary care standpoint, the emergency room standpoint, and then certainly as oncology providers ourselves, being able to recognize these and why it's important that we take these medicines, like why you come for your monthly injection of Xgeva, or why we check labs so often, and things like that's really important as well. Treatment needs to be initiated as soon as possible, and as with most things in medicine, and certainly in oncology, largely focuses on the underlying cause. So finding out, is this from the cancer itself? Is this related to a treatment that we have the patient on for their cancer? Or perhaps a treatment that's not even directly for their cancer, but in conjunction with the cancer, or another treatment for the cancer could be causing some of these as well. Is it a physical problem from the cancer itself, a thrombus related to the cancer, the port, and things like that? Certainly, if you're taking care of patients in the primary care or emergency room setting where you're not an oncology expert, that's okay. You don't have to be. Just knowing that patients have cancer, and especially the certain types of cancer that we discussed, these are more common in, should help add things to your differential, or rank things higher on your differential as well. There are plenty of references here, and I think we are ready for questions. So we're going to use Poll Everywhere, I think, again, for questions, if anyone has any to add in.
Great. And I will be moderating and looking for those questions. We have a little bit of time left. So this is kind of a nice incentive for our audience to go ahead and share as many questions with Allison as you can, in part because we have to make sure that we make it to that 50-minute mark so we can get everyone credit. So this is good news. That means we're challenging all of you there listening to go ahead and share your questions with Allison, and then we'll go ahead and I've got one for you right now, and I think we should be able to get to that time mark as well. So let me start. And this is something that I was just learning about the other day. But what has been called bisphosphonate-related osteonecrosis of the jaw, and I know that some folks are saying, "Hey, we should really call it medication-related osteonecrosis of the jaw with medications like denosumab as well." So, how this is from my understanding, a really, really horrific condition that can occur, and where the bone starts to die in the jaw and can be very painful and disfiguring. How is it? This is, I think, with bisphosphonates, maybe 1% in the first year, 2% in the second year, something like that. But how do you weigh the concerns about these medications with the benefits?
Sure. Oh, that's a great question. So I unfortunately have had a lot of patients who have presented with osteonecrosis of the jaw, and you're exactly right. It can be excruciatingly painful. It limits how they can eat, and so that's a big quality of life issue and a health issue as well. And so certainly when we're talking about someone who has severe hypercalcemia and we're in an emergency situation, then weighing the risks and the benefits, it's really going to be important to use that initial IV bisphosphonate to get that calcium under control. Certainly, we might also do things like the calcitonin and steroids as well to get that down so that they don't have to kind of do those maintenance denosumabs and things like that. There's also a lot of literature saying that we really need to limit the duration that we have patients on these continuous bisphosphonates or denosumab treatments as well. Just like you were alluding to, the risk of ONJ gets larger every year that the patient's on these. So that's something to keep in mind too, is these are not medicines that we just put patients on and then leave them on forever. It's something that we really need to monitor. Also, a side effect that I think we as providers just don't generally do a really great job of educating our patients on. I've had many patients who came in and they were like, I went to the dentist for my checkup and they told me that my jaw is rotting away or some phrase that they've used. And yeah, so that's something to really be aware of as well. We also hold those treatments. So if a patient is requiring extensive dental procedures or extractions or things like that, and not when we're treating for an emergency situation, of course, but for the maintenance therapy, we will hold those treatments sometimes for a couple of months while the patient is undergoing extensive dental procedures. And unfortunately, if a patient presents with osteonecrosis of the jaw, we very rarely, if ever, would put them back on those medications. So then we would have to go to some other options and very close monitoring of the calcium levels to make sure that they're not getting into a dangerous range again.
Understood. And then and so a recent extraction is actually an added risk factor for osteonecrosis.
Yes. Or sometimes just severe dental caries as well. So I know we partner quite frequently with our dentals. We're very fortunate here at UNC to have a dental school on campus as well that we could partner with our patients with. But that can be really, really difficult as well, especially for patients who don't have access to good dental care.
Right. Well, thank you. We do have another question. So this is for patients with SIADH. What do you typically recommend regarding how much fluid restriction you would tell you would be involved for your patients with SIADH?
Sure, that's a great question. And I don't think that there's an across the board answer because every patient has their own factors and things we'd have to consider. If they're a patient who's on a really strong chemo that's causing a lot of nausea and vomiting, we certainly don't want them to get dehydrated as well. So really just balancing those things. So the first things I would look for would be, trying, if they're on any kind of diuretics, things like that, to stop those so that we're not flushing everything out so much. So as far as fluid restriction, it would just vary by the patient.
Right. Thank you so much. So let's see. Let me look and see. And again, for our audience, we do have time for a few more questions. So please go ahead and submit those through Poll Everywhere, and we will go ahead and take as many as we have time for. While we're waiting to see if additional questions come in, what's on the horizon? Are there treatments? Are there medications? Are there other things that you're looking at and saying, hey, that's not quite there, but it may be there soon? Or let's start there, and then I have a follow-up question to that.
Sure. So I would say my personal experience with these three has probably been the most with hypercalcemia, since our breast cancer patients, it's more common in that population. And so I think there's a lot of information about different dosing strategies we can use for denosumab and the bisphosphonates and things like that as well. And so I think that'll be really interesting to see that maybe we can get away from having to give these super frequent injections and things like that to prevent it. So that's what I'm excited to see.
Great, great. And then what's on the wish list? If there were something that you just go, gosh, there's such a need for this, and it's just not there now.
Absolutely. Well, first, the wish list would be that no one has, that we'd all be out of
Yeah,
jobs, and there would be no
absolutely.
cancer for any of these patients. But
Yeah.
unfortunately, I think that's probably not a realistic goal. So I think my wish list, personally, coming from as my background that we discussed, I came from public health and then went into oncology. And so what I think is really important is just educating our primary care providers, our community providers, our emergency room providers on all of these things that affect patients with cancer. Because we're all focusing on the same goal of taking care of the patient. And sometimes the primary care providers are seeing these patients more often or may have had a longer relationship with them than the oncology team. They're more local, so they may be able to access them more easily. And so if our primary care providers can sort of be more aware of these kinds of situations, then we might catch them before they become true oncologic emergencies and when they're more in just that risk zone rather than the full-blown emergent issue.
Great, great. And it looks like we just had another one come in. There we go. So how do you handle cases where you're having trouble with a diagnosis?
Oh, that's a great question too. So as far as cases where we're having trouble with the diagnosis, so I imagine, as we went through these cases, you can clearly see that there's an abnormality. Our case with that SIADH was very obvious that the sodium was low. We knew that, but we didn't know why. And so, from an outpatient perspective, there's not a lot of workup that will be safe for a patient with a sodium of 118 to do in the outpatient setting and send them home while we're working on that. So a lot of times these are patients who are going to need to be admitted and have further workup that includes, multimodality imaging to look for extent of disease, further lab work, sometimes things like 24-hour urine collections, things like that are just not practical to do in the outpatient setting. So, unfortunately, a lot of times these patients are going to have to be admitted as far as completing the whole workup and the diagnosis.
Great. Well, thank you so much, Allison. This has been fascinating. We really, really appreciate your expertise and time. Let's see. We've got a few other things I need to do to wrap up, and then I'll check and see if any last questions have come in. We always want to say thank you first and foremost to you, also to the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Venny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all of the work that they do, and that each of them plays a part in making these lectures happen.